Good afternoon, and after the 2-week hiatus, welcome back to Grand Rounds. Please remember to fill out the attendance log at the back of the auditorium, and also please remember to fill out your program evaluations, and if you could, give the CME committee any ideas that you might have in regards to future topics or future speakers. Today, I am very pleased to have the opportunity to introduce Dr. Nicole Gastala. Dr. Gastala is a board-certified family practitioner. She did her residency at the University of Iowa. Currently, she practices full-spectrum family medicine at Primary Health in Marshalltown, which is a rural federally qualified health center. What's particularly germane to today's talk is the fact that she also has special interest, expertise, and licensure in chronic pain management and medication-assisted management of opioid dependency. The CME committee is really pleased that she was able to come over today and provide us with an overview of the primary care and comprehensive pain plan. So please join me in welcoming Dr. Gastala.
Thank you. Well, thank you for having me today. I graduated from the University of Iowa a couple years ago and was really excited to start at my first practice. I'm in the National Health Service Corps. And at the university, I hadn't really seen a lot of patients who identified as having opioid use disorder, but when I came out into practice, it was pretty common to find once you started screening for it, and then really trying to get control of the opioid overuse and prescriptions that were occurring in our community. So with the help of Andrea, who is here with me today, she's our nurse manager, and she will also be available to answer any questions as well about how to set up a program in terms of MAT as well as chronic pain management. And we all know that the spectrum has changed, right? We went from 10 years ago or 15 years ago where they created the pain as the fifth vital sign, and you did not do your due duty and diligence to patients if you did not appropriately treat their pain. And this is part of the problem that we've had in Iowa, is overprescribing of opioids for the length of time and the amount. Now they're switching and finding that there's a lot more problems, and now it's our responsibility as providers to really look at our patient population, work on their chronic pain, but in a safe manner now that all this data has presented itself. So the objectives of this talk is really to understand what guidelines we have now in terms of the CDC and how to do office-based primary care pain management, as well as appropriately screening patients for opioid use disorder, and then coming up with a plan to be able to treat those patients, and how you as primary care physicians or subspecialists can help identify patients with opioid use disorder and then help them get the appropriate treatment if needed. So about 11.2% of the adult U.S. population identifies that they have some issue with chronic pain. And about 3 to 4% of adult U.S. population are on long-term opioids. And there's really a lack of evidence for greater than 12 weeks of treatment with opioids. And about from between 1999 and 2014, there was a significant number of overdose deaths, and you can see this in the media quite frequently. And there are about 1.9 million people who abused or were dependent on prescription opioid pain medications. And in primary care setting, we have a problem with opioid dependence, and it ranges between 3 and 26% depending on the practice. So it can be pretty significant. And about 1 person dies every 19 minutes from a prescription drug use, and this really affects the way that we treat patients. So a little over a year ago, due to this opioid crisis, the CDC came up with guidelines or recommendations on what we can do as in a primary care setting to treat chronic pain, just to kind of help us, because before there really wasn't any guidelines. There's very subspecialist guidelines that were very challenging to really understand and do in a primary care setting. And the very first recommendation is non-pharmacologic therapy and non-opioid pharmacologic therapy. And these are preferred for chronic pain, and this is based off of evidence. The thing that I know is challenging is, what do you do? It's very easy nowadays, to not start patients on opioids, but what do you do when patients are currently on opioids, right? the important thing is to consider, now that these new guidelines are out, to really try to step back and look and get a good history from the patient. What medications, non-opioid medications, have they tried in the past? How long were they on it, and did they get to the most effective dose? For example, you have a patient who will say that, oh yeah, I tried gabapentin. Well, how much gabapentin did you try? Well, I tried 300 TID and it didn't do anything. Well, that's not close to the effective dose for diabetic neuropathy. So perhaps it's worth revisiting with that patient. So really detailed history is important. And in terms of the Iowa Board of Medicine, very important to document that you are having these active discussions with the patient of medications that they have tried in the past, and the dosing and how long they were on it, and if they had any side effects as well. You want to consider opioid therapy only if expected benefits for both pain and function are anticipated. And this is what's really important. So when you ask that question, what is your pain today? And they say my pain level is a 7. How many of you have had patients say every single time, no matter what opioid they're on or dose, will say their pain is a 7 or an 8? It's never under control, right? So it's very challenging to use just that number as a basis if it's really showing improvement. That's the benefits outweigh the risks. So when we talk about function, well, what are you able to do now that you weren't able to do before? So for example, if they work, we see a lot of patients who work at JBS, at the meat packing plant. Perhaps it allows them to work consistently. Perhaps it allows them to take care of their elderly mother, or they're able to do more of their self-cares. And so setting those goals with the patient at the beginning, saying, where are you at now? What function do you hope to achieve? And then documenting that throughout the process, that they are in fact achieving their goals and able to improve their function. It's important to establish realistic treatment goals with all patients. Goals should include when and how an opioid will be discontinued. And this is very important for setting those boundaries with patients. So a patient will be discontinued on an opioid if so and so and so and so. And what I mean by that, if they're found diverting, if they're found not taking the medication as prescribed, if the risks outweigh the benefits, if there's not an improvement in both pain and function. These are all reasonable reasons why you would taper or discontinue an opioid medication. And you want to provide, when we talk about realistic treatment goals, your goal for pain is never going to be a 0, and that's unrealistic to expect that. What is an acceptable pain level for you? What is an acceptable level of function for you? If we meet that, then and we're still safe, then we've helped meet that goal. If your pain level is always a 7 through 9, your function's not improving, then this medicine isn't really improving and helping you, and the benefits do not outweigh the risks. You want to provide patient education. So if there's no clinical meaningful improvement in pain and function, the opioid medication will be discontinued. And a lot of this, if you do not have now, is usually in the patient agreement that you have, that you discuss with them at their first visit when you're prescribing opioids. So if they're transferring or if you're starting a new pain program in your clinic, you say, we are going to be going through this document. And this is important because it explains the benefits and risks of the medication, as well as expectations from both my end and your end, because this is a dangerous medication and we have to make sure that you're getting the most benefit out of it, and as well as being as safe as possible. And so a lot of this should be in your agreement that you go over with the patient, and that helps set boundaries. And it's really important to participate in an open and honest discussion about benefits and risks related to all treatments. So having that discussion, with the Iowa Board of Medicine, you have to document at least once a year that you've discussed that opioids increase their risk in terms of their driving capacity and operating heavy machinery. That has to be documented once a year, and that's specific for our state. And so you need to have that open and honest discussion about the risks of opioids. And there's a lot of tools out there that you can use that will break down their risk based off of the risk factors. So for example, the VA came out with a really great tool a little over, I think 1 to 2 years ago. It's called RIOSORD, RIOSORD, and it takes into account not just the opioid medication, so the milliequivalents of morphine, but also takes into account, do they have COPD? Do they have cirrhosis? Do they have any other mental health problems? Are they on SSRIs? And it comes up at the end with a percentage. What is their percentage risk of respiratory suppression? And then you can use that as an objective tool to have a discussion with the patient saying, look, your risk of respiratory suppression is 55%. This is unacceptable and unsafe. We have to work on making this safer for you. And we not necessarily can't change some of your chronic diseases like a COPD or cirrhosis, but perhaps you have to choose between your benzo and your opioid. Which one do you feel more of a benefit, because of the black box warning puts you at much increased risk of respiratory suppression, and we don't want you to have any harm. And so that's one of the tools that you can use from an objective standpoint that can help you have that active discussion. So you're having a collaborative discussion with the patient, not saying you will do this, but let's work together to make this as safe as possible. And it's also important to educate patients on the responsibility for managing pain management and therapy. So that means should be in your document as well. If you give them a prescription and they lose it, you don't refill it early. If they aren't taking their medications appropriately, there's no early refills without talking to you. If they're doing a lot more than they should and they haven't brought it to your attention and they call 14 days before their refill and say, I'm out of medicine because I was using it more than I should have, that's not a reason for an early refill. Asking patients, setting that boundary, you cannot call in and expect a refill that day. If you have to give 5 to 7 days to allow the refill request to go through, because it is a controlled substance. You have to pull a PMP. So all of this takes time. And we've had you would think that this would put a lot of hindrance, but it actually creates a safer and more productive environment for not just staff but patients as well, because there's less chance for provider variability in terms of what will or will not occur in your clinic, and it helps set the boundaries and expectations from the patient standpoint so that they know, okay, I'm going to run out early, or this is not working for me, my pain is much higher, and this is not adequately controlling. I need to come back in for an earlier appointment than what I was scheduled because it's not working. So it makes the patient more an active component of their care, rather than always coming to your office in crisis because they ran out or whatever, or lost their prescription, whatever it may be. It's also important to evaluate their risk factors, and you want to. There's a opioid risk tool, ORT, that you can use. And this will help you delineate if they have a risk of addiction or a history of addiction. It's also helpful. And this determines how often you follow them up. So when you see a patient for chronic pain, you want to see them at minimum every 3 months. If they're medium or high risk, you may want to see them every week or every 2 weeks or once a month, depending. And that has to do with their risk factors. It's important to check a PMP for doctor shopping, multiple ER visits, dental visits, as well as multiple prescriptions from various towns or areas. You can also pull a PMP for the states surrounding us, except for Missouri. They do not have a PMP. So you can do that, and that you have to document. It's very important to note, do not scan the PMP into your medical record, because according to the state, that's not allowed. You can just document that the PMP was consistent, or the PMP was reviewed and not consistent, and what was inconsistent about it. And one of our addiction patients had told us that she would go to the ER frequently, or the dentist frequently, and purposely not fix her teeth because they would prescribe a month's worth of opioids, and that's how she was feeding her addiction. So it's important, if you see that significant number of dental visits or ER visits for dental pain, but no actual treatment for it, that it's really important to talk to the patient. Why aren't you, and dig a little deeper to see if there's perhaps an opioid use disorder. It's also important to do routine urine drugs testing or oral swabs, and this is helpful not just to identify the correct use of prescribed medication, but as well as the non-prescribed meds. And this is the best practice is to do it prior to writing a prescription. You want to do it at least once a year. Random is best, and then more frequently if they're at higher risk. And this can also help you, depending on which drug screen company you pick. If they say they're taking a medicine and that it's not working for them, you can actually check to see. So they say, oh, only that medicine with the D works for me, meaning Dilaudid. And you try gabapentin or one of the tricyclics or duloxetine or Cymbalta, you can actually check to see if they're taking it. Because we've had patients who have said, oh yeah, I take that and it's not doing anything. And then when you do the drug screen, you'll see, okay, your Cymbalta level is 0. You're not actually taking it. So let's have a discussion about this on why did you stop it, why did you not start it, because that's an important part of, you have to work with me and you have to try those non-opioids before I'll continue prescribing opioids for you, because that is part of the CDC guidelines. And when you have that discussion with the patient, it can be hard, but you have to say, I have to treat a lot of patients, and I need to protect my license. And this is part of protecting my license so that I can treat other patients as well. So we need to work together to come up with the best pain plan for you. It's really important to try avoiding concurrent benzo and opioid prescribing. And this has to do with a new black box warning that came out from the FDA. They potentiate each other, so they will potentiate the risk of respiratory suppression. So it's what we do with our patients. We say, okay, you're on a benzo and you're on an opioid. Which one do you feel works best for you? It's not safe to prescribe both, so which one do you feel like is most helpful? If it's anxiety, we know best practices do not recommend chronic benzodiazepine use. And we know that SSRIs are the medication of choice, with benzos to only be used periodically. So have that active discussion with their psychiatrist or have that discussion with the patient, because you want to make sure that you document that and that the patient understands that there's risks, and it's really about picking which medicine works best for them. It's also important when you start doing chronic pain, or if you are continuing to do chronic pain, what do you do when you start screening, right? So you're starting to screen with urine drug screens, you're asking those challenging questions which may not have come up before. And what do you do when you find a patient who has opioid use disorder? Who do you refer them to? What's your next step and plan? Are you going to offer something like naltrexone or buprenorphine? So knowing your local community partners, your substance abuse treatment unit is really important as well. It's also, the CDC recommends using IR opioids, so immediate release opioids when starting. Do not use long-acting when they first start because of the increased risk. So the rule is to start low and go slow, use caution and reassess frequently. So acute pain, this has changed significantly than how many times did you prescribe 2 weeks, or a surgeon may prescribe, a month or two. And now it's really, you want to do 3 days or less and then follow up. More than 7 should be rare. And if you're not seeing them frequently enough to see where their pain should be improving or not. Chronic pain, you want to reevaluate frequently. So if a patient's new to you, about 1 to every 4 weeks, and then monthly, and then every 3 months will probably be your maximum for those patients who have a really low risk of misuse. So those are the guidelines that 60-page document kind of summarized in shortly. You can read the full one, is on the CDC website, but that's the most important points that I think for primary care practice that will really help, as well as our subspecialists too. So if you're trying to work on your chronic pain program within your clinic, decrease the opioids, finding alternate, you really want to create a process and workflow. If you can, create a care team. If your EMR can accommodate it, create a checklist. So what do I mean by that? Can you check a box that says the PMP was reviewed? Can you check a box that says that You counseled them about the risks with driving and operating heavy machinery. Did you counsel them about the side effects of the medications? So really trying to streamline that in your EMR can be very helpful. And it also serves a purpose to you as well to remind you of something that you may have forgotten. Create a protocol. So if a patient fails, what are you going to do? If they end up having an opioid use disorder, what's your next step going to be? You really want to create a controlled substance agreement because, as I said, it creates consistency within your clinic. It creates consistency with providers as well. You don't want one provider who refuses to do urine drug screens ever, because certain patients will seek that provider out, and then they'll transfer care to that provider because that one's not doing drug testing. So it's really important to create a protocol and an agreement that has all this written down that all the providers go by as well as the patients comply with. And then the most important thing is consistency. So it's not fair to treat one patient differently than the other. Well, my little old 80-year-old lady, I don't need to drug test her because she would never abuse or sell her drugs. Well, that's not necessarily true. If her Social Security income doesn't cover enough, sometimes there have been patients we've had who have sold some of their pain medication to help cover their cost of living, and that's not uncommon. When you do a urine drug screen, there are two different kinds. So you have your instant urine drug screen, and those are notorious for being both false positive and false negatives. They're usually a 10 or 12 panel. They'll say morphine, but they won't break it down. They'll say opioid, but won't break it down. The really best thing to do is send it out for confirmatory, and you have to document why you're sending out for Medicare and Medicaid. You have to document why you're sending out for confirmatory. So you can say, says positive for opioid, but need to confirm that it is the opioid that I'm prescribing, and there's not another opioid in their system that they're not misusing. So as long as you document that, then you're covered from the standpoint of the word's escaping me, but adequate use of medical resources is pretty much what that helps cover you for. And that really helps you determine, are they using any other medications on top of what you're prescribing, and are they using it correctly, and is there anything else in their system as well? And as I said, you can also use these to confirm that they're the send out, usually not the instance, but that they're taking their tricyclic, that they're taking their gabapentin or whatever it may be. And what's nice is it will show you the metabolites as well, and it goes back about 5 to 7 days depending on the drug screen. So if they say their last dose was last night of their hydrocodone and their screen comes up negative, then they're not being honest with you. They haven't had any opioid in their system for at least 5 days. So how do you use these different tools? So there's the brief pain inventory. These are just some listed that you can look up later. CAGE, the modified instrument of activities of daily living, the opioid risk tool, and the Bain disability index, and as well as the reassure tool, which I had forgotten to add on here. These are all different tools that you can use to objectively help the patient meet their goals as well as assess risk. On your team, it's really helpful if you can have a behavioral health consultant or counselor if you have it in your clinic, an RN, it can be LPN, MD, PA, but you really want to have, if possible, we have a weekly meeting where we discuss our MAT and chronic pain patients. We go over difficult cases, we go over drug screens and have that discussion, well, what's our next step and what's our plan with this patient? It gives us time to review the inconsistent drug screens and make a plan of care for the following week. So as you know, a lot of chronic pain patients can be sometimes a bit challenging to work with. And so it's good to have an idea in your head based off of if these drug screens are consistent or inconsistent, what you're going to do next sometimes before you go in the room, so that maybe you're not necessarily manipulated a different way. And it's also really helpful to it's hard not to be emotionally involved with patients sometimes, especially if you've been really working really hard to control their pain, to have that outsider perspective and that feedback from your colleagues to say, this is appropriate, this is not appropriate, this is what we think the next step should be. So I've got a couple case studies. So this is a 58-year-old male with a past medical history of COPD. He's on HOMO2, morbid obesity, OA. He transferred to Care. He was on hydrocodone, acetaminophen, max 6 per day when he transferred to me. He had 2 negative drug screens that came up. It turns out that he was diverting his medications to supplement his income. And this would not have guessed this based off of his story or his appearance at all. So it just goes to show that it's really important to not categorize patients, but in fact be consistent and treat everyone equally. Then you have a 47-year-old male. He has morbid obesity, type 2 diabetes, depression, anxiety, ankylosing spondylitis. He was being prescribed opioids as well, and his screen came up negative twice, and he had no explanation for why. So the medication was discontinued, and he cried when it was discontinued. And we asked if he was upset, and he said, no, he's happy. Well, it turns out that his wife, 46-year-old female, she had a history of gastric bypass, anxiety, was a CNA, presented to us later with a diagnosis of opioid abuse, and she had been stealing his pain medication, and it was causing a really challenging marital time for them. And so by having that discussion with them, we were able to help another patient in our clinic who had undiagnosed opioid use disorder, help her seek treatment and help really support that couple as they went through this very challenging time. Again, would not have guessed based off of the patient. So where do patients get, or non-patients get, their pain relievers from? And most get it free from a friend or relative, and they usually get it from one doctor. And so this is why it's very important to do the drug screens, because you don't know where the medicine's going after you prescribe it. You need to make sure that they're actually taking it. So the next part of the talk is about medication-assisted treatment. And so this is for patients who self-identify as having an opioid use disorder, or through drug testing, you have that active discussion with them and they identify and meet criteria for opioid use disorder. And this is very important because there's a very gray area sometimes between chronic pain and opioid misuse or opioid addiction, right? And this is very important for us within primary care to try to address. So as we know, the overdose deaths have considerably harmed the country throughout the U.S., but definitely in rural areas are affected as well. In fact, the rate is increasing in rural areas compared to the large metro areas. The number hasn't been higher, of course, but the rate is much higher, is increasing in rural areas, which is a lot of where you guys serve as well as we do. So what do you see when someone presents with opioid overdose? Well, you see respiratory depression. This is the usual cause of death and why it's so important to counsel patients who you do prescribe opioids to. They can present with coma, hypotension, pinpoint pupils, but may dilate later with hypoxia. They can get non-cardiogenic pulmonary edema, and the antidote is naloxone. And this can be given intramuscular, intranasally. It is very poorly orally absorbed, so you do not want to give it orally because it won't do anything. So why is this important? Well, substance abuse really negatively impacts the health of the patient. So I cannot control my patient's diabetes or their hypertension or their chronic kidney disease or any of these other conditions that they may have if I do not treat their substance use. Because when someone has an addiction, that is all they think about, right? They cannot, it's just, they're in such a negative place where they're really focused on just getting their next fix, and their home life is out of order, their employment, and their other chronic conditions. And we know we're moving towards an era of value-based care. So it's really important to look at a person and take care of the whole person, because if you're not treating their opioid use disorder, you're never going to treat their hepatitis C, right? it may masquerade as an illness that a patient does not have. So, for example, hypertension. How many of you seen methamphetamines and causing pretty severe hypertension in the ER or in your clinic? It can contribute to non-adherence to prescribed regimens, and it can interact with other medications they're taking, which can cause toxicity. And then treating addiction is a significant contributor to cost containment, especially decreasing your ER visits. So there are 3 FDA-approved medications for opioid addiction. You have methadone. Won't really talk a lot about that because you have to be at a registered narcotic treatment program, which I believe, which UCS does in Des Moines. Buprenorphine, which as long as you get your DEAX waiver, which is an 8-hour training for MDs and DOs, and a 24-hour training for PAs and NPs. A lot of them are free right now because the government is pouring a lot of money and helping contain the opioid epidemic. And this one is pretty safe. It has, it's only a partial agonist, so it can't, if a patient is addicted to opioids, it will not cause that high because it only partially activates the receptor. It has a pretty good safety profile. It's really hard to overdose on it because of that ceiling effect. And this comes as Suboxone or Subutex. Subutex is without the naloxone component, so without the antidote. The reason why Suboxone, it has both buprenorphine and naloxone in it. Naloxone is what we give when someone's having a heroin overdose, right? So what it prevents is that buprenorphine has about a 30% bioavailability if it's taken orally, and naloxone pretty much close to 0. If, however, the patient melts that film or tablet and injects it, it has 100% bioavailability. But the naloxone will beat the buprenorphine to the receptor and block it. So it'll put them into immediate withdrawal. So that's the deterrent part. So that's why the only way they can take it is orally, otherwise it'll put them in withdrawal. Subutex is buprenorphine only. I only recommend using that in pregnant patients. I would not use that because it does not have the naloxone component, that deterrent component to it. Naltrexone is a complete antagonist, and it comes both orally as well as long-acting injectable. So this is pretty helpful for patients who have recently been incarcerated and have already gone through the withdrawal and are really just looking for something that will help with their cravings. And it's nice because it does come in the long-acting injectable. However, the long-acting is expensive and it's hard to get covered sometimes. Naltrexone is also indicated for alcohol abuse as well. So it's nice that it can be used for both. And there is some very small data that naltrexone can help with methamphetamine, and I've seen, about 50-50 on that in terms of we have a lot of methamphetamine patients in Marshalltown. So if you look at Iowa, we are not as bad as some of the states next to us, but we do not have enough buprenorphine prescribers, and this was printed in the Annals of Family Medicine about 2 years ago, and this is something that the Iowa Department of Public Health is working on, as well as with medication-assisted treatment expansion grants that are offered throughout the state. So hopefully we're trying to fill in some of those gaps, but the little gray boxes just means that there is at least one provider, and we know one provider is not enough for a whole county, let alone a whole section of the state. And that's because they limit the number of patients that we can have and we can prescribe buprenorphine to. So when we talk about the different opioids, the full agonist, which is methadone, oxycodone, heroin, and that attaches to the mu receptor and fully activates it. The partial agonist is less reinforcing. It activates at a lower level, and this is what buprenorphine falls under. And then you have naltrexone and naloxone, and that falls under the complete antagonist. So it binds to the receptor, it helps with cravings, but it doesn't activate it at all. And this just shows the mu receptor intrinsic activity with each of the components. So how does it work? Well, it has a really high affinity for the mu receptor. It competes with other opioids and blocks their effect. So our patients will sometimes, if they try to use other opioids like Vicodin, it really won't affect them or affect them negatively. It displaces heroin or other opioids from the receptor, and it can produce withdrawal if the patient has opioids in the system. So it's really important that when you start buprenorphine on a patient that they come in and withdrawal. And I'm not talking about complete 3 days withdrawal, but their COW score needs to be about a 7, so their last dose of an opioid should generally be the night before if you're going to do a morning induction. So they have to be in slight withdrawal, and then you give the buprenorphine, and then it helps with withdrawal symptoms. It has a slow dissociation, and it lasts for about 24 hours. There's a ceiling effect, so it has really, it's not great for intoxication purposes, and it's really safe in overdose. And it's formulated with naloxone, so it blocks the effects if it is injected. So this is a brain scan that activates the mu receptors, and you can see that once you get to a dose of about 16, in terms of buprenorphine, about over 90% of the mu receptors are blocked. So that's usually the most effective dose that we work at with patients. So what does buprenorphine help with? Well, if a patient is actively using heroin or other opioids, it helps with their withdrawal symptoms and detoxification. So it prevents withdrawal, it diminishes their cravings, it doesn't produce that high, and it blocks or reduces the effects of heroin. And it really increases a patient's treatment retention. And it's really the standard of care. So, and as you can see, this study was done quite a long time ago, but it compared buprenorphine with methadone, and at 17 weeks, it had a pretty good treatment retention. If you compare that to just counseling alone, that's like 7 to 10%. So it's not really enough. And this just shows that if you use one of the modalities, you can increase and have a 90% reduction in heroin use in your community. So what are the additional components? Well, they have to have psychosocial services, and this is required with your DEAX training, and it'll say that they have to either they have to be in some sort of substance abuse counseling. And what I tell patients is that the medication helps stabilize you. It helps with the withdrawal, it helps you from feeling those withdrawal symptoms and going through withdrawal, and helps stabilize your addiction, decreases cravings. But we know that that's not the root of the problem, right? So most patients, they have to go to some sort of counseling or therapy or substance abuse treatment, because that's really what's going to get at the core of the problem. Do they use opioids as a coping mechanism? When they have pain or when something happens in their life, do they turn to heroin or one of the other modalities? And really the substance abuse treatment is what helps patients learn what other coping mechanisms can I use, what else in my toolbox can I use to help me cope when I have these stressful situations so I don't go back to using again. And whether that's individual and group, family therapy, 12-step, but this is a requirement in our program. We do not do medications without the therapy because it has the most important outcomes, and the patients, that's just one of the requirements that we require within our program. So it helps with lifestyle stabilization. It improves health and nutritional status, decreases your criminal behavior as well as employment. I had a patient who went from being unemployed homeless drug dealer who is now working at Menards and has been there successfully for a year now. And that's an amazing, we don't see that in medicine. Where else in medicine do we see that sort of turnaround? You have an opportunity to make an extensive impact on your patients' lives as well as your community's lives by offering this. And it also decreases injection drug use, decreases HIV as well as hepatitis C. So take-homes for Matt. It really helps with withdrawal while patients are undergoing counseling and substance treatment with the end goal of tapering to the lowest effective dose and abstinence from using heroin or other opioids. It's safe, effective in suppressing withdrawal symptoms. It helps with cravings, and it blocks the effects or reduces the effects of illicit opioids. It's very safe, has a low likelihood of clinically significant problems. Most of the time when they've seen overdose or morbidity and mortality has been linked when they've used other drugs, such as benzodiazepine. So I do ask patients to not be on a benzodiazepine whenever, or see that number decrease to 0, because it does take a while to get out of their system, so that we decrease their risk of potential problems. Patients can continue to function, so we do inductions in the morning, and then in the afternoon they're back at work. It really helps with their home work environment. It doesn't cause disruption in their cognitive or psychomotor performance or cause end organ damage. There's a diversion potential does exist, but it's much less than opioids or methadone because you can't melt it or inject it, and it has that sealing effect. That can be done in a primary care office after you've had the DAX training and set up your program, and really you have the ability to change the outcomes of patients in your community. So thank you. I hope I didn't go over, but thank you. If you have any questions.
I have a few questions, but I'll just ask a couple here to start with. For your drug screens, how often do you have a person in the emergency department have a false positive opioid screen? Is that pretty rare, or is that pretty common?
Yeah. So RER uses only the instant test, and that one can have false positives and false negatives. It's important that you work with your ER to try to get them to send it out for definitive testing, and that will tell you for sure. But it can have false positive negatives, and that's why Medicare and Medicaid will pay for the definitive testing. You just have to send it out and say that you need confirmation.
Okay, then, so there are some false positives.
Correct.
But how about
Not on the send-out ones. Those are never false positive.
Right,
Yeah.
but the ones that probably we in Marshalltown do, there could be some occasional false positives. Then my second question is, what about fentanyl and some other opioids? Are they not picked up on some of these routine drug screens?
Yeah, so sometimes, like the one in the Marshalltown ER does not check for buprenorphine. So that one can, if you're not checking for it, it won't show up. It comes back as a generic opioid or morphine, so it won't tell you, it won't delineate which one it is.
Okay, but the fentanyl sometimes not picked up with a routine drug screen?
Correct.
Yeah, okay.
It depends on the panel that they choose.
Okay, my last question is, how do you decide which patients should go into your Suboxone category for treatment? We have a guideline here that if patients are on opioids for more than 2 months, we want our physicians to have a medication management agreement. And we've been developing a toolkit for our physicians to manage those patients with chronic opioids. But which patients would you say are the right candidates for the Suboxone, the buprenorphine treatment program?
So there's two sorts of ways that you can go. So buprenorphine is FDA approved in 2 different ways. There's buprenorphine or Butrans patches, which can be used for chronic pain. Buprenorphine Suboxone, which is a different, which is the film or Subutex, that is only FDA approved for opioid use disorder. So you really have to delineate out the safety and what the patient, so if the patient's being treated for chronic pain and that's it, then you would want to do the Butrans patch. If they identify as having an opioid use disorder, or you confront them about having an opioid use disorder, whether that's through inconsistent drug screens, they're taking their medications inappropriately, if they meet criteria according to the DSM-5 for opioid use disorder, that's when you'd want to use Suboxone. And that's how the FDA kind of segregates the same drug but in 2 different ways. And the Butrans patch is really nice because it's once a week, right? You give them 4 patches, and it really is helpful for chronic pain. And the risk is very low, again, because it doesn't have that, or it has that sealing effect. It's very hard to overdose. It's not like fentanyl patches or something like that. But again, insurance is our most limiting factor. We have a lot of Medicaid and uninsured patients in our population because we're an FQHC. Getting V-Trans patches covered is very, very challenging, even though they want us to work on the opioid crisis, but then insurance companies limit what we prescribe, and their preferred medications are hydrocodone or things like that, and the medicines we want to prescribe, they make you jump through all these hoops for, even if they're safer, just because of the cost. So, yes. Uh-huh. Yes. You have to sign them once a year. Absolutely. We actually just updated ours. So, and we made it for controlled substance agreement. So that means it can cover any controlled substance. So whether that's Adderall or opioids or benzos. So, which is nice to help with consistency too. Yeah. Yes. So there.
Who pays for the psychological counseling for the patients with opioid withdrawal? What are your social services available to you in Marshalltown?
Sure. So each area is a little bit different, but the counseling services are sometimes covered by insurance. If they're not, most community addiction treatment centers like Satusi have a sliding scale available for patients. They can also apply for grant funding to help cover that as well. But a lot of places will work with the patient, and they'll say, I can't afford to come 4 times a week to do the intensive therapy, but maybe I can afford to come twice a month. And then maybe they'll in return do Narcotics Anonymous as their balance to do group, because that is, of course, a free organization that they can join. And then the Narcotics Anonymous, counselor will have them. They'll just bring a sheet and say, sign that you went to those, to show that they have some compliance with the group activities as well. Yeah.
Do you have any idea what percentage of your chronic pain patients that have stayed in your clinic that you've been able to transfer from opioids to non-opioid medications?
How much would you say? Percentage is hard. Do you want to talk to that? Come on. She's our manager, so she is the one who keeps track of everyone and everything.
I would just say that we started our program in 2014, and we probably had over 100 patients that we were trying to get, the ones that were on opiates, get them under control, and get the ones that were misusing either off or under, using appropriately. We probably have maybe 60 now, and we're trying to prevent people from starting who don't need them. And I think we're doing a pretty good job now. I mean, we don't have the problem that we had. We aren't getting yelled at the front desk anymore.
A corollary to that is that the non-steroidals have a bad name because of cardiovascular risk, and obviously they're used for chronic pain for people. How do you document that in the chart, saying that you're using them for beneficial reasons to get over the risks of chronic non-steroidal use and potential litigation as a result of that?
So then I usually write that, because it's all about risks and benefits. So the risks of opioid suppression, or of respiratory suppression and accidental overdose due to all of the factors, and that's where the Reassort tool can really help you, because you could say, if I start this patient on an opioid, they have but due to their other health problems, they have a 50% risk of respiratory suppression in this next year. And that is, and discussed with the patient, the risks and benefits of controlling their pain and improving their function with NSAIDs outweigh the risks that can be associated, and the patient understands and agrees to that. And that's what's really important, is having that conversation and documenting that, because any medicine we give has risks and benefits to it, and it's about, does it improve their function and help them in the long term, and then talking to the patient about doing drug holidays, switching out with Tylenol. But you can also document that you're following the CDC guidelines, who do recommend that Tylenol and NSAIDs be tried to help treat chronic pain. And that is considered standard of care now, right? So if you go to court and have litigation, you just have to refer to the CDC guidelines and say, this is what the standard of care is and this is what they recommend. And we had that active discussion. Sorry, not the best. It's not the best. You have to work with it. Until they can come up with the magic pill, I don't know. It's hard.
Is there a line that you draw between patients with a terminal painful illness, I'm thinking of cancer, and ones that don't have the terminal illness? And if so, how is that line defined by the bureaucracy?
Sure. So the CDC guidelines are only for non-cancer, non-palliative patients. So there is no in terms of the bureaucracy, there's no restrictions on cancer and palliative care. So if a patient is on hospice and doesn't have a greater than 1 year life or 6 month or 1 year life expectancy, and then you just document that. So you don't have to worry about following the CDC guidelines in terms of that, but you still have to have those. You still have to follow the Iowa Board of Medicine requirements, which are, documenting that you had the discussion that they can't drive or operate machinery once a year, and that they and that you discuss the risks and benefits. Of course, that's always important, but there's no bureaucracy that covers cancer or palliative. Any other questions? Thank you.